Good afternoon, everybody. Welcome to today's meeting of the Health and Overview Scrutiny Committee. I'd like to remind everybody present that this meeting is broadcast. You'll see what's being broadcast on the big television screen. And it goes on the County Council's website. And it then also will be available not just live, but also available on the archive for people to view afterwards. So if everyone can remember to switch their microphone on when speaking, and then turn it off when they've stopped speaking, then the camera's going to zoom in on the next speaker. Thanks very much. So, getting started, the minutes of the meeting we held on the 16th of January. I propose the minutes of the meeting held on the 16th should be taken as read, confirmed and signed. Agreed? Thank you very much. I've not received any questions from the public this time. Okay, page. However, a question asked by members under standing item 7.3 and 7.5. We have actually received a question. Has everyone got a copy of it? Yeah. So we've had a question from David Bill, and there's been an answer provided on it, and it basically is a follow-up, really. If I just summarise it for people watching it, this is summarising the fact that last December we supported the bid by West Leicestershire CCG to the NHS for money for the Hinckley hospitals, and the Secretary of State replied, and almost on the same day then told the CCG that they could go ahead with the rest of the proposal. And so what Dave is asking is, time's pressing on, what's happening? And in the response, essentially, we've come across this before as part of the Overview Scrutiny Committee, particularly with the joint one we have with the city. There is a process which the NHS insists that people bidding for money goes through, and instead of like having a consultation first and then doing a business case and then applying for the money, it sort of goes the other way around almost, and you don't actually get round to public consultation until an awful lot of the preceding work's been done. But you do have to get NHS to approve that you are, that the plan is sort of essentially will go ahead provided you tick all the various boxes, and that's really what's said here. Particularly the fact that they're aiming for the next stage, which is the pre-consultation business case. That's likely to be available between July and September this year, which still is nearly 9 months after the original sort of get going. And then there's more consultations take place. Then there's outline business case, full business case, before eventually they may get round to NHS England being approving or not approving that everything's gone through the various stages. So it's quite a process, and we've had this before. I said it's not new, although obviously with Hinckley Hospital it's new, and it's the process that the NHS has. But anyway, David, do you have a...
Sir Chairman, and many thanks for your comprehensive response. It does confirm what I suspected, that it is a long and tortuous process, which I think people will struggle to appreciate. Could I ask, though, that looking at the last sentence about County Council officers being in regular contact with officers at the CCG, could I ask that local members are kept appraised of progress? Because we are interested, we are concerned, and I think a regular update would be of use. Thank you, Chairman.
Yeah, it sounds perfectly sensible. I suspect it isn't going to be very regular because the state at which this goes through, there's only 4 stages in it, so you may get one every stage, but there's going to be months between each one. But I think it would make sense. I mean, especially as this committee is being involved in this, obviously through in its question, the letter we wrote to the Secretary of State. Okay, everybody. Right. Then item 4. This is other items which has been decided to be urgent, and the answer is there aren't any. Declaration of interest. Anybody got any particular interest they want to declare on the items on the agenda? No? Good, thank you. Declaration of party whip. Any members have any declarations about party whips? Petitions. I've not received any particular points about petitions, so we're on to the first substantive item, which is item 8. It's on the papers, pages 11 to 24, and this is on the cancer performance update. So, we welcome members on the opposite desk from where I am. So, Paul, are you going to take this on?
I will do. Thank you very much, Chair. First of all, can I just introduce Sam Leake, who was the Director of Operational Improvement at UHL, and Dan Barnes, who was UHL Cancer Lead at UHL. Apologies from Vivek Vakavansam, who was supposed to be here today, but his wife's poorly, so couldn't actually make it. So apologies for that. I think just before I start, I think it's worth to note that I think part of the last meeting that you had, the committee that you had, there was a question about understanding the cancer standard in more detail. I think there's been a bit of cross-purpose because actually if you look at the overall performance report later on the agenda, it covers a lot of the cancer elements. So I think whatever we talk about right now will be within the context of that report, and I'll try and refer to some element of that as we move forward. So what we've done is to take an opportunity to tell you a little bit more about cancer, what's going on, to give you some of the context around performance. So what I'll do is give you a bit of a synopsis of the report because I'll take it as read. Okay. So again, I think the initial question around the performance metrics is at page 11, which needs to be read on page 104 of your pack. I think a few things to say really. I think while there's been some steady improvement around the 62-day performance, we're still not meeting the standard, and that's pretty evident to see that. I think there's some context around that though. So when you look at our peer performances, I think East is about 2nd out of 11 of its peer, and I think West is about 3 out of 11. So actually that's not to say it's not an important standard, but actually it is usually important. But actually when you look what's going on across the East, actually we're sort of above the middle of the pack. So I think that's quite an important point. I think part of the other elements that we get measured on is the stage 1 and 2 of cancer diagnostics, and we're sort of middle of the pack there. So when you look at the way we are actually sort of monitored and performance accredited, if you want, it does say in there it needs improvement. Now that's because it's those 4 measures, and actually those 4 measures are the ones that are taken, and not the whole remit of other measures within the cancer. So that's not to say that we actually need to do some work. So I think it's probably helpful for me to give you a bit of, I think, the story around what do the figures tell us really, and I'll give you a little bit of a synopsis around some of that. What we do know from all the data that we have is where there are capacity issues like need for locums and things and what have you, then performance can be quite variable, and actually that's something that my colleagues either side of me are dealing with on a daily basis in to make sure the gaps are plugged and everything else. And by and large, the system reacts quite quickly and tries to put things right the following month or within the forthcoming week. I think it's important to also note that our 2 weeks referral has significantly gone up, and I'd like to point out that's not a bad thing. It's actually what we want to see, and that's usually important because this is about early detection rate. And again, not to decry from the need to hit 62 days, but actually when you actually look at our performance, despite 15 and probably a 40% increase for the last 4 years of our 2 weeks referral, performance stayed steady, it hasn't deteriorated, and actually if things hadn't been improving, you'd have seen an absolute deterioration of performance, I think. So actually that's the context really of that performance. And despite all of that, I think there's some bits I probably need to point out. One of the measures that we do get measure on is actually the treatment once diagnosis has taken place. And actually, if you look at the headline figures, 97% of our patients are treated from diagnostics. Okay, and that's really quite important. The other element is our survival rate, our 1-year survival rate. So we currently stand at 72-73% respectively, East and West, or West and East, apologies. Actually, the target for 2020 is 75%. So actually, we are doing really well in that respect. As I mentioned earlier, our stage 1 to 2 is middle of the pack, and we need to do more work. And I believe we're getting some publication in March to tell us last year's performance, so we're almost nearly a year and a half, 2 years behind in terms of the publication of those figures. And I think more importantly, the cancer patient experience is 8.8 against a target of 8.74. So actually we do quite well. So I think, what does that tell us? I think that tells us that we do reasonably well in terms of outcomes and in terms of action once we know somebody's got cancer. We know we have a problem in terms of diagnostics, which is actually to try and speed up the diagnosis of patients. And by and large, that's what our focus has been, certainly the last year or two, around that element. I think it's fair to say that we've seen a transition of how cancer is performance managed in terms of data. And one of the reasons there was some confusion last meeting is because we started with that shift. So the most important one is 62 days. So whilst we're still monitoring other things, that's not the one we necessarily measured on. So again, that's why you spotted the 31 days further down the paper and said, what's that? But I think more importantly, it's going to change again. There is a consultation coming out at the moment, and we're going to be looking at 28 days from referral to diagnostics. And we're already starting to think how we shadow monitor that against pathways because it's about early detection. 62 days is going to remain as a measure of whether you're achieving that. And I think the other one is the treatment, again, from diagnostic to treatment. And again, I've pointed out we're doing relatively well with that one. So, just in sort of conclusion, really, I think the team has done some significant amount of work over the past years or so. We certainly improved the quality of referral that we're seeing. We're certainly seeing an increase in our referrals, which is what we want to do, and that's through good primary care engagement. My colleagues aside might say, please stop, but actually that is the right thing to do, and we have ongoing discussions because, again, patients need to be seen and to be diagnosed. And I think what we also decided to do is to really focus on the key pathways. And you'll note in this document, we've actually given you a bit of an update on the three main pathways we're really focusing on. And those are obviously lung, colorectal, and prostate. Now, interestingly enough, through my discussion or our discussion with the Cancer Alliance and the wider field, we seem to be quite ahead of our field in terms of some of the things we're doing around the pathways. And as you notice, sort of the first phases of most of those pathways either have already been put into place and we're looking to see what's happening, or just about to be put into place around prostate and what have you. So again, my colleagues will be able to give some more details around those particular pathways should you want it. And obviously, one of the big areas is living with cancer or recovery, and we've got a program of work to do some of that. The last thing I would like to say is about 3 months ago, I agreed to take on the cancer agenda. We've reconvened an STP-wide cancer board, and we are currently re-looking at all our terms of reference, the relationship with the Cancer Alliance, a relationship with specialised commissioning, and trying to come up with a definitive strategy and operational plan moving forward to, again, some greater clarity and further clarity around our next steps. So I'm going to stop there, and I guess I'm going to open for some questions.
Any questions for anybody? No? I have one particularly. In the pathways, the colorectal pathways pages, it refers to a particular treatment, I suppose, or testing anyway, of FIT. It wasn't defined as what FIT was. I did look it up.
Hi. So it's fecal immunochemical testing. There we are. So it's, I think people have heard of... Sorry? Still none the wiser. No, that's fine. So are people aware of fecal cold blood testing, sort of stool samples? Before I go into too much, yeah. So I think the best way to put it is it's a much more sensitive, better version of that. So that actually as a test is going to be rolled out for bowel cancer screening. They're yet to decide exactly when, as they're still going through the procurement phase for the kit. But due to the fact you can alter the sensitivity of that test, which you could never do with the old FOBs, it's starting to be used in higher risk patients, which comes into what you're going about, the actual patients who, by their symptoms and so on, are at risk with cancer. And actually, I think that's one of the big good news stories for our areas. Both us and Nottingham are one of the first areas to operationalise using that test. And it helps triage patients that come in, because we have a huge number of patients that have various symptoms that might point towards bowel cancer, and it helps triage them to actually get the right patients seen as quick as possible first time. Because obviously the name of the game, at least for us clinically, is to get those patients at the front and to diagnose them as quickly as possible. And that's what all of the East Midlands Cancer Alliance work that filters down to us is aimed at, is at the early detection of, particularly we're aiming at colorectal, at prostate and at lung. Hope that helps.
No, that does. I mean, as I said, I Googled it, so I knew what it stood for, but I thought it would be worthwhile everyone else finding out as well. And that's useful to know that, because I hadn't realised it was going to replace the FOB, so yeah, that's handy as well.
In the future, yeah.
Sure.
Yeah.
So I shall have to go through that one more time, probably. Okay. The other issue, which was mentioned right at the start, was about capacity, and clearly that's got to be with obviously not just the capacity to be able to handle what comes through the door, but obviously also the fact that Leicestershire, like everywhere else across the country, is having a lot more houses, therefore a lot more population. So the populations are going up, and then clearly at the same time you need to have the healthcare processes available to match the same capacity, don't you? I mean, you feel you're going to be able to cope with that?
We've got a programme of transformation that we're undergoing at the moment with each of the tumour sites. We were fortunate to get approximately £1.2 million of transformation money from the Alliance. That's for this year, and we've started projects that will roll into next year. The bidding process for new projects is about to start, and we're confident that we'll get additional funding to do more transformation. We've absolutely acknowledged that we can't keep doing more of the same, and we've got to do things radically differently, and as a team we're looking at how we're going to do that going forwards.
Sarah.
Thank you, Chair. I mean, I'm pleased you redesigned the pathways, because when you've been in the pathways, you sort of sometimes think, well, why does this take so long? You've got a certain amount of work, yet it all seems to get dragged out over much longer than is otherwise the case. I noticed somewhere else in the long-term plan it says, yeah, diagnosing cancer quicker will ease, or not cancer, will ease patients' sort of concerns. Yeah, that's the worst bit, waiting to find out whether you've got something or not. So I can only applaud that. It's a shame currently the statistics aren't where you want them to be. But one thing that did cross my mind is, one thing is, you know, speeding up doing multiple tests to try and do them in almost a day, which I gather you do already for breast cancer, but maybe for other things. And if we're trying to catch things earlier, which of course makes treatment simpler because, you know, there's less to deal with, this doesn't really touch on screening, and I know that kind of falls outside of your remit, but how are you going to poke NHS England, for want of a better expression, to improve that?
So, again, I think you're absolutely right. We held a workshop a short while ago to start kicking off, so what does the strategy look like? And of course, the strategy starts with prevention. So we had a lengthy discussion around how does public health, for example, fit into that. And part of the reason we are doing the piece of work, we need to try and join up all the dots. And so that's a point well made. And I think the other point around, you know, being the patient, as some of us have, you know, been that patient and having to do the wait, then actually we are having discussions sort of at primary care level to say, actually, how do we improve the communication between the diagnostic set and if you want what the GP is facing with the patient, what do I tell the patient, sort of discussion, because that's quite awkward and quite difficult for both the GP and the patient. So we are aware of that, and the faster you speed up with your processes, the more the communication needs to be spot on, otherwise it causes problems. So we are aware of that. That's something we're working on at the moment.
Amanda.
Thank you. The table about the 2-week rate for referrals to go through, you obviously had an increase. Has the throughput, as in the people who have obviously received a diagnosis, has that also increased in line with the numbers of people coming forward? Or are you doing more sort of preventative screenings? What's been the trend?
I'm sorry, I'm not sure I quite understand the question.
So on table 2.2, it identifies as being an increase of 15.9% of the amount of people who've gone for investigations. Once people have had that investigation, is that increasing by 15.9% in terms of cancer diagnosis, or actually is the throughput generating less?
So I think you mean the conversion rate. So yeah, no. We're just it isn't actually in there. There isn't that increase. So the pickup rate of the pathways set by NHS England is actually meant to be about 3% for these pathways. So in effect, we investigate a lot of people to try and pick up these cancers earlier. So off the top of my head, in most of the tumour sites, the conversion rate has stayed stable. It's not rapidly gone up. So, which is, frankly, in all honesty, although again I'm sitting on the provider side, we probably do need more coming, through the door. In all honesty, so.
David, yeah.
Let's pick on the last point. Obviously, I discuss these things in passing when I see my GP. And am I right in thinking that there's a problem that, although people are invited to come in for tests, that only a percentage of the population actually takes up the offer? And does this actually mean that people are at risk because they do not respond to the letters that come in, and encourage people to
start to respond. If I miss something, Dan will pick up any of the things that I missed. I think the short answer to your question is yes. I mean, the reason there are targeted screening is because there is a group of patients where we know there are risks. So if public health put them some say you need to go to your GP or what have you, then and they don't turn up, then there is by definition a risk that something might be missed. That is something I think is exercising people both locally and nationally into how can we improve the response rate. I don't have the details at my fingertip to give you the current discussion around that, unless either my two colleagues can do so. But I do know that one of the things that we are trying to do, which is slightly converse of the coin, is to be much more sensitive. And when we know an educational drive has been published, we stand ready to respond so that we can do it in a very timely fashion rather and capture the patient, if you want, as quickly as possible. That doesn't fully answer your question, but a simple answer to your question is if there is a targeted screening and somebody doesn't come, then actually theoretically there is a risk that something might be missed.
No, obviously if the Public Health England domain is screening, but I think one thing we should go from the figures that you're seeing for the 2-week waits. Obviously, if something's picked up in screening, it then filters into our cancer pathways, but that part is separate. I do actually applaud there's some good work going on within LLR to do with helping for uptake of screening across all the main modalities, which I think has been positive, and fortunately we've got no one here from that particular area, but I think we can assure there's good strides being made, particularly with awareness within particular demographics.
So I can pick up a little bit on that. There is something called NG12 compliance, which is actually all the red flags you might expect to see if somebody presents. So one of the things we've done through our electronic referral process is to make sure those red flags are identified for the GP. So actually what you're seeing is an improved referral, quality of referral and consideration. So at least if the patient gets to the GP, they're much more aware really of what they should and shouldn't refer, which is in part why you also starting to see some increase in referrals.
Mike stands out.
Yeah, if I may come in. So, screening programmes are, of course, the public health responsibility of NHS England. So I'll absolve both myself and my colleagues in Public Health England for responsibility for their declining performance. In terms of what's happened since 2013, I guess, the fracture that was the Health and Social Care Act, what we should be doing locally, and I think Paul's referred to this in the earlier bit, is almost what can we do on the ground through local authority public health to help attract people back into screening programmes. So that's less about the invite. For me, that's more about targeted work around early symptom recognition, both in terms of professionals and public, and doing that kind of on-the-ground support in different settings. So you're talking to people more naturally about why they should be coming forward for a screening programme. That, I think, is the local opportunity that's for us to decide rather than for NHS England.
Yeah, thanks, then. I think that's probably everybody. Yep, no one else has a question. Well, thanks very much. I mean, that's brought us up to date, as you said, and we look forward to the next ones, obviously now with different targets, which is always the case. So item 9 is Health Watch review of winter messages, which is Michael Smith. Are you going to stay there? You can do.
If that's all right, I don't see the benefit of moving a couple of
I
seats.
agree. No, fine.
Thank you, Chair. I've brought a draft of the report for everyone's information, and this is just for a bit more context. We did some work with some workshops in Leicester City and in Leicestershire with support from our colleagues in West Leicestershire CCG from the public health team there. So whilst we were having a conversation with members of the public around their awareness and what impact the winter messages around public health had, we also had somebody from the public health team to then go through some of the messages that were going out in the winter, so there was a chance to educate as well as to find out what people's understandings and awareness were. So whilst I'm not going to go into the report in too much detail unless there's anything in particular people want me to kind of touch on, and we can cover that in a minute. I think what the report does really kind of demonstrate is that mixed understanding from members of the public, that some are aware of it. It's interesting to see that under the flu vaccine that there's still members of the public that believe that having the flu vaccine gives you the flu, when it's biologically impossible for that to happen. So just kind of represents sometimes, I think, the struggle that the public health teams are facing against what seems to be very deeply entrenched kind of misinformation. But it just then emphasises the need to keep on kind of hammering home the messages, I suppose. It's also quite interesting to see about the reach of the messages that a lot of people hadn't seen, or they weren't aware of some of the messages that was going on. And from a personal perspective, I thought we were being absolutely bombarded by public health messages over the winter months. So again, something that we're going to be working with our colleagues in Leicester and Leicestershire, specifically around public health, so we can try and unpick some of these findings so we can see what that's going to drive. I think what was certainly interesting from our perspective was the feedback that we had of patient experience when they'd actually gone to the pharmacist. This is going to be quite a focus for public health messaging, certainly kind of moving into it was over winter and moving into spring and summer, around the different parts of the health services that people link into. I don't know if you know about DEMERS, which is a new process where patients are going to be referred into pharmacists from NHS 111. And if the feedback that we received in this is symptomatic of what patients are experiencing, then they're not being signposted to a very helpful service, and we're potentially going to do some more work around that. So that's an interesting kind of pickup that we've had from there. So I think as far as the kind of recommendations, as I say, it just really kind of emphasises that the public health messaging, it's just an ongoing need, and whilst the messages are going out there, there's maybe a kind of a consideration about whether or not the old methods and methodology that's been used, if that isn't working, whether or not there can be some work around how that can be done in a slightly different fashion, and rather than just kind of putting the information in front of people, whether there can be a more kind of two-way conversation around public health, which is potentially something that we can work with our colleagues around.
I mean, I've certainly, this year, in fact, is the first time or this season, that I've had a flu vaccine actually from my GP practice, because up to now I've been a member of the NHS, and the hospital has brought us forward and given us various incentives to try and get us all to have it. This year, they said no, because you're now over 65, which I've been actually for 5 years, but for this year, obviously, there was a separate vaccine, and they said best go to your GP, which I did. But I think that confused people as well. Actually, there was this differentiation, and it wasn't clear why to most people. So I think that you're right. The mixed messages we're getting through, and I'm amused, but that's because I'm an ex-microbiologist. But I'm amused by the fact that people think it gives them flu. I think that's a good one. But yeah, anyone else? Yeah, Janet.
There's rather a confusion over the ages for, on page 29, other vaccinations. Do different surgeries work a different system? Because I went for my flu vaccine with my husband. I was told I couldn't have my shingles vaccine because I wasn't of the right age. But my husband was a few years older than me, and he came into the category to have the shingles. It's a bit confusing, so I was wondering if you could clarify anything, please. Thank you.
Just to point out, I'm not a part of the NHS. We very much are trying to capture and to represent exactly that experience, that for kind of moving away from the traditional kind of flu vaccines, there is some kind of confusion around exactly what's happening, but maybe my public health colleague. I think it's a question that we are going to be taking away and challenging with our public health colleagues, not just in the local authority but also within the NHS, and it certainly highlighted that. And just kind of going on, just if I may, just back to your point, Chair, around the flu vaccinations and the age difference. There was locally, and it seems to kind of be something that we saw nationally, around about October, November time of last year, there was a real push in the press, in the television, in the newspapers to get your flu vaccines. But if you're over 65, you couldn't get one. They'd run out. And this was something that was identified as being a supply issue. So it was interesting that the kind of the timing seemed to really mismatch, and whilst it was resolved relatively quickly when the next tranche came along, from the public, it was very much a, you're asking us to do this, we've gone and done it, and we physically can't. So there was another kind of slightly kind of like an this moment.
Go on. So if I come in, you know, when you look on the agenda and the first two agenda items, you think, oh, there's nothing much in it for me, and everybody starts talking about public health, which is a bit of a worry. Firstly, I can't help but comment on people's beliefs about what causes the flu, because I'm reminded back in swine flu days in the pandemic in 2009, I had one question which asked me, is it true it's a government conspiracy that's spreading the pandemic flu virus? And then I got mentioned on a forum in the David Icke website, I kid you not, which said that the flu virus was being spread by vapour trails from jet aircraft. So frankly, if people are getting the jab thinking it's got them the flu, they're actually pretty rational compared to some people. In terms of this year's flu campaign, again, you know, we've got a role to play in helping promoters, a bit like the previous conversation about cancer and symptom recognition and prevention. There is a role for local authority public health in maybe working a bit more on the ground about how do we push messages to people that need to pick up their flu thing. One of the issues for me this year was, again, to blame NHS England, could have communicated better where we were up to with ordering vaccine, because it was quite clear earlier on that a certain type of vaccine wasn't going to be fully available and there'd be sort of stocks coming through during the course of the flu season. And that message didn't really quite get out there, which did lead to people then rocking up for their flu jabs and being directed elsewhere, and sometimes GPs and pharmacies are having to order kind of alternative supplies. So by the end of the flu season, it seemed to have caught itself back up, or caught back up with itself. But there was a spell when I was certainly fielding some queries from people who thought they were getting vaccines that they shouldn't have done, and having to allay fears that it either wasn't in stock or it wasn't being done correctly. So I think that's one of the learnings from this year's flu campaign.
Chairman, then, I've not got an answer to what I've asked, so how do I get my answer as to do surgeries work on a different system by giving these shingles, or do you have to be a certain age, or why are some getting it and some not? I just needed some clarification, if possible, please.
As it's something you'd need to kind of raise the question through the clinical commissioning groups for them to kind of pose it to the providers, so that the GP practices.
But if we do that, we'll... Yeah.
Okay.
Thank you, Chair. A couple of things that have been useful with this. One is to know the ages of the participants, because you get an impression reading this that they're mostly older people who are over 65, but I don't know, and it would have been useful to understand where people are coming from, depending on the age. So that was one aspect. And it would have been nice to have had more than just one in Loughborough for the county, because that's a very urban, even by county standard place, and it's a big diverse county. So that was that comment. And my only other thought, Chair, is that pharmacies vary. I've been in 2 pharmacies in Market Harborough about a query, and one was far more useful than the other, and I know where I'll go back for advice in future.
I totally agree with you. I mean, I know you obviously were limited by what you could do, but other areas of the county may have different conclusions.
The approach that we took was actually to reach out to a number of kind of known community groups that we interact with, to come to them and to do the kind of the workshop. So it wasn't that we specifically targeted Loughborough, it was just where the group was based. But I completely take your point, and absolutely take your point around the inconsistencies as far as provision is concerned. So yeah.
I mean, obviously, this is I would imagine, a fairly small sample. There's been quite a lot in the press about the anti-vaxxers. And did you get a sense there were people who were electively choosing not to get vaccinated?
We didn't kind of get much of I think the anti-vaxxers where they're quite passionately kind of anti-vaccinations, but we certainly got some feedback which was people concerned about what's in the vaccines. And there's reference to one member of the public talking about there being mercury. So again, it's that kind of the battle against the fears and concerns about what people are putting in their bodies. But no, we didn't really get any kind of sense of that kind of anti-vaccination, the fears and concerns through the kind of historic reports around and the links to autism. So.
I have to say I did like the comment you made about the people from America, United States, that the news anchors were vaccinated on air. I thought, yeah, the one show, I can just see it now. Sorry, good thinking. Next item then is the urgent emergency care resilience. And if you remember, this follows on from the pre-winter discussion we had about in September about winter preparedness. We're now after the winter, are we? Probably. So we've now got Mike Ryan here with colleagues to talk about sort of how the winter has gone. But I presume it's over.
Negative, not over yet. First of all, thanks for inviting us back today. It's a bit earlier than I think we wanted to do. We are planning, in the midst of planning our comprehensive winter seasonal resilience preparedness, how it went basically for May. So we're going to probably send out some invitations as well. With me today is Sam Leake from UHL, Richard Lyne from EMAS, and Nikki Beecher from LPT, our partnership trust, who provides both mental health and community services. And there's some other folks who couldn't make it today, but one of the reasons why we're all here is to demonstrate the one team sort of approach to how we actually approach winter planning this year, to build not just winter resilience, but to start the process for 12-month resilience, really. Today, I think, is a bit more of a stepping stone in terms of how we're reviewing our overarching process and also performance. As I said, we will be going into much more further detail come May, but as most of the folks will appreciate, certainly I've been harassing people since I think winter and the weather started back in October, November, to constantly get a bit more continuous feedback, in particular from Health Watch colleagues as well. So this isn't today presenting an overarching comprehensive view or review, but just wanted to make sure we highlighted what was coming over the next couple of months. We know last year was extremely relentless. We also know a lot of it's in the paper, but a lot of it was effectively we got caught out and we're behind the power curve from the get-go, and it was relentless to the point for staff and patients, I think, for everybody involved to play catch-up. There was quite a lot of a negative experience, I think, overall, but this year we took all those lessons learned, built them and embedded them into our overarching priorities as a system. I think we've seen some pretty positive results so far. It's not perfect. We are working to obviously continue and improve as a one-team system. Also, we know people living longer based on research and development, improved medical interventions, but also people are moving to Leicestershire, Leicester City and Rutland. The Strategic Growth Programme from 2011 to 2031, which we're smack dab right in the middle of it now, highlights about 100,000 homes being built across the geography, which will obviously have quite a significant impact upon demand anyway. And beyond that, following 2 decades, we're probably going to see roughly the same amount of homes built too. So it's not only an attractive place, but it's also bringing a lot more demand. This past winter to date hasn't necessarily seen the same level of weather conditions as we know, although we do have, I think, Storm Gareth knocking on the door. And this time last year we said, what a great winter, wasn't it? And then we got snow towards the end of March. So knock on wood, we are prepared if we do get colder weather and not so great weather overall with plans, etc., and people quite disciplined and regimented to pull those out as necessary. Having said that, we have had a higher level of demand for services inside hospital and outside hospital, across urgent treatment centre, primary care, ambulance services, community services, than ever before. I think within UHL, the increase ranged between 6 and 8% a month increase of A&E attendances. Ambulance services, I think the average last year per day was about 174 ambulance conveyances to hospital. Yesterday we had 220 show up, so there's quite a significant increase there, demonstrating that actually it's a real credit to the multi-agency teams, including social services, for all the hard work they're doing to maintain services in a positive way. Having said that, performance has marginally improved between last year and this year, and if I may, the 4-hour standard, I call it a standard because I think it should be a standard rather than a target, noting that there are very few organisations nationally who are achieving this standard. We, I think, at UHL have gone from roughly 79 to 80% delivery on average to about 83, 84%, which again is marginal, but it's been about establishing this stability so we can genuinely improve performance as we go. Likewise, we've seen quite a sizable demand increase in ambulances, so another sentinel indicator, as they call it, are the ambulance handover delays, which was a significant concern last year. And at the same time, we've had some peaks and troughs in terms of performance, but we've had a better grip on managing that. So last year, I think roughly 58%, which still isn't obviously good enough, were delayed over 15 minutes once they arrived to hospital. 15 minutes is the standard. This year, to date, is 52%. And yes, those are numbers, but when you think about the sheer numbers and volume, it can be quite significant for a number. We've also spent quite a lot of time establishing the right plans and multidisciplinary team, clinical team, to make sure that from, well, February was a huge improvement, actually, as outlined within the paper, starting to see some real traction and improvement so that we're getting down to even below 30 to 35%, bearing in mind the regional average is about 55 to 60%. In total, across 18-19, we did build in the areas of improvement identified into our plans, but we also, as I said earlier, focused heavily upon winter schminter. Let's build resilience 12 months of the year to build this, going further and be a 12-month focus. So we focused heavily upon the general resilience and stability and multi-agency working. We did bridge quite considerably into the practical aspects of winter, namely within councils. Do we know what the gritters are doing? Do we know what the stores look like? And included, quite a sizable amount of communication improvement there too. Fire services as well as police, we bridged in with that, as well as obviously with Public Health England, as well as infection control colleagues and nursing colleagues. So it was more of a broader bridged plan rather than here's a document, there you go, let's go. So it was about people and practice and processes, which I think we've borne the fruits of positive aspect. We also, as reported previously, focused heavily upon frail patients and multimorbidity patients, those patients with quite a few presentations in the past, but also a number who are on a high number of medications and or have a number of issues with themselves, so that primary care colleagues in particular can identify those patients in advance and try and put the right care plans in place and connect services appropriately. I won't steal Sam's thunder in terms of all the weird and wonderful things that UHL did in terms of planning ahead around how they organize their capacity. But what I will say is part of the overarching positive output, we've had very few elective cancellations as opposed to last year, which was a very, very challenging year last year, nationally mandated actually. But also we've had a significantly, we haven't had many at all, I don't think, time-critical or cancer-related cancellations, and where there have been any, they've been strictly based on clinical reasons, as far as I'm aware. Beyond this, I think Michael just highlighted an evaluation of winter messages, which is extremely useful. We're also trying to understand the effectiveness of our winter messages across the system. We've had some positive feedback, and there's an appendix within the paper relating to the campaigns that have been put in place. Some of them I think have been more effective than others, but we will continuously monitor and improve as we go. And again, we're already talking, we shouldn't be yet, but we're already talking about hot weather planning around messages, so we don't get caught out. So all humour aside, it's been a one-team approach to build that system resilience. One of the mechanisms we've put in place, which I've really pushed, and colleagues around me will recognise and acknowledge that I probably harassed on occasion, the importance of something called operational pressure escalation levels, which is a framework to determine where we are in terms of genuine pressure. Really pushed last summer and into the autumn to define what our business as usual was, meaning the effect of last year not understanding that when we're super busy, we're all super busy, whether it's summer, winter, or whatnot. So it's actually understanding what actions we needed to take collectively, not just leave it to UHL to sort themselves out or EMAS to sort themselves out. So we defined a lot of the business as usual and aligned the actions that everybody would take based on that situation to enable streamlined communication, which, as you will know, when it comes to a hectic environment, communication, if it's poor, creates chaos, and well, it just pushes escalation even higher rather than getting towards prevention and de-escalation at a faster pace. And it should be noted that whenever UHL or others have been highly escalated to say an OPEL 3 level on a scale of 1 to 4, in light of this framework we've agreed, it's enabled the de-escalation at a much faster pace. I'm quite proud to say. So in total, don't want to steal everyone's limelight or take advantage of too much time, but although we're not any means perfect, we are going to continue to build on the lessons learned. We're going to have a full comprehensive review in May. We're already building up towards that. There does remain room for improvement, but we are in a much more stable position, which, even though there's been a marginal improvement to performance, the reality is we're in a bit more stable foothold now that we can start to see improved performance overall. The one last thing I'll point out is we're capturing a lot of patient stories in particular, so we can galvanize people around why we are here and doing what we're doing day in and day out, which is about patients and getting back to that. So part of the review we'll focus on will be not just about performance, but also about patient experience and the quality of outcomes, not just about what we've done, but also where we're going and what we want to do in the future. Okay?
Maggie.
Thank you. Capacity and attendance seems to be a theme that runs and a concern that's running through nearly all the papers we have. So whether it's from early diagnosis to ambulance waiting times to living with cancer and the projections going forward. So my question is really, what are we doing to address that capacity issue going forward? And if I may, I'd just like to give you a patient story. And looking at your papers, the last committee I attended here was on the 21st of January. From that committee, I had to go with my mum to the hospital as an emergency. Unfortunately, there were 17 ambulances waiting in front of us, so of course we didn't meet the handover time. And I sat with my mum for nearly the whole of the night before my sister relieved me at 8 o'clock the next morning. But what I will say is, never at any point during that time did I feel that my mum was neglected or we didn't know what was going on. The teams worked as a multi-team and they worked together and they worked brilliantly. And to sit and watch what happened during that night, I couldn't say anything else could have been done because you were really at sheer capacity. There was nothing. So that's where my question is coming in. How do you address that capacity?
Thank you. I think one of the most important things is the positive feedback, and we'll make sure that goes back to the team because our priority is to make sure that patients are safe, and that sounds as though that happened, which is good. We, as a hospital, that's our priority. We don't want to be putting patients in a corridor where they're not safe. If we're looking after patients on ambulances, and I'm sure EMAS will want to comment on this as well, that might be the safest place for people to be. And you're right, this is about fixing capacity through the hospital. And we've started to look at that earlier this year. So as Mike said, this winter is better, next winter will be even better. So we've started looking at our capacity and demand gap now. We've started looking at transformational programs that we can put in place in the summer when people have time to put transformation in place so that we're ready in winter. And we'll know what our gap is. We'll never get to zero gap. We don't have enough beds for every patient that will be coming into the hospital, but it's about ensuring that our processes are as efficient as they possibly can be and as safe as they can be for patients. Does that answer your question?
It does. It goes away to answering the question, but as I keep coming back to, there was nothing more your teams could have done on that night because everybody was working to their full capacity, but it was just the sheer numbers, and this wasn't a severe winter, so we're not at a severe winter, so we've hit capacity already and we've peaked, and what I'm trying to say is, how are we going to get over that capacity that we're already at? You know, it's fine putting transformation and everything in, but there's certain points of days that we're hitting, and no matter what we're doing, it's that capacity and that pinch point at that time that needs addressing.
So if I give you one example that might help, so we have vacancies in nursing and vacancies in medical staffing, which is a national problem. That means that patients on wards aren't being seen as often, or they could be seen more often. That might shorten the process of a patient stay on a ward. So we've got a recruitment drive going on this year. We're looking at skill mix on wards to do things in a different way. That will enable patients to be seen more frequently, that will enable us to ensure that they can be managed through their process, managed through their patient pathway in a more time efficient way. There's also links then to LPT, and Nikki might want to pick this up. So if the next step for a patient is through to the community hospital, it's making sure that that happens as quickly as possible.
Anyone else want any points about this? I mean, clearly, you know, there are improvements. I mean, there's no doubt about that. That's obviously to be supported. But obviously, as you mentioned, the fact that the previous winter, the elective operations went out the door for a month or whatever it was, and clearly that gave you a bit of extra capacity. But as I spotted when I watched the programme about Queen's Medical Centre Nottingham, you just got the consultants sitting there more or less twiddling their thumbs instead of obviously operating on people. So that it has some pluses and some negatives, doesn't it? But so it'd be good to see, yeah, obviously how this progresses, particularly for next year. But Janice, you've got a question. Yeah.
I will refer to that, can I?
Yeah.
Sorry, Chairman. Mine's a bit of a grumble. Having read the agenda, which was very long, a lot of the certain paragraphs keep repeating themselves, and when I come to on page 49, the evaluation update, I've been looking at all the papers, cuttings from papers and photographs, and I've noticed that just one point is that one gentleman is on a photo 7 times, the same sort of photo. So, and it's all paperwork and work, and I was wondering how that could be probably scaled down a bit so that we just see one of the photos instead of all those repetition photos of the same people. Thank you.
Absolutely. Apologies for that. I think the individual who was in multiple photos was the lead for winter communications, so I think he got a bit of credit there. But noted in terms of how we present that. Yes. Yes.
Just thinking. I mean, obviously, it was mentioned by Maggie, and clearly we've discussed with EMAS in the past, you know, your response times and so on. I don't know what your views are, how this winter went.
And again, quite rightly, you pick up, I've sort of been to a number of the combined scrutiny committees now to talk about response times. And we're making good progress on those. So as Mike alluded to earlier, what we're seeing at the moment is a 7% increase in our 999 demand compared to last year. Yet in terms of response times, we're making a really good inroad into bringing those down. So a few examples are our category 1. So these are really poorly patients, cardiac arrests. We've moved from last year where we were around a 9-minute mark to around a 7-minute 15 second. So shaved around 2 minutes off there. And when we in category 2, which are still poorly patients, we've reduced that the mean average by 21 minutes, and the 90th percentile, so 9 out of 10 patients, we now get it to 51 minutes quicker. So we've still got some way to go to get to the national standards. I think a lot of this is down to the work that we're doing as a system. And to pick up on some of the early points around capacity, we're doing a lot of work to look at how we can stream our 999 calls away from ED. So some simple examples that my team are working on with UHL at the moment are looking at how if a patient needs to be seen in the surgical assessment unit, let's just get the patient straight up onto surgical assessment, not funnel through ED, who will then just take the patient up onto surgical assessment. So how can we bypass ED to take the demand off there? Because you're quite right, what we see is pinch points in the day. and that's where that capacity and demand doesn't meet, and we see the unfortunate handover delays. But we're also working wider around actually saying, can we keep patients into more of the community services? So can we use the urgent care centres better, and forward looking about, can we empower our own crews to make more decisions on the scene and put in packages of care? And a lot of that is dependent on our workforce plan, because I think when I've come and spoke to you before, we were lucky to attract additional funding, and again making really good inroads in that recruitment. So since this time last year, when I originally came to speak to the groups, we've increased our headcount by around 70. And there's still a number in training. We're expecting 20 members of staff to come out of training, and that's going to carry on till next year. So those response times we're hoping to bring down further over the next 12 months. So there's a lot going off across the system.
Thanks, Richard. I just thought it was worthwhile having an update, so that's very helpful. Yeah, it's good to hear that things are getting better, so be good. Okay, well, thanks very much, all of you. Very good to get the update. Oh, sorry, Bill. Oh, sorry, Sarah. Sorry, Sarah.
I start to feel like donkey in Animal Farm at this point, because, you know, I've been and discussed too many winter pressures reports, to be quite honest with you. And on one level, fundamentally nothing changes, and on another level, I suppose it does. I'm pleased things like the trolley breaches and all of that is getting better, and I think we've got to definitely, I mean, without having to cancel elective care, there's a better grip on things this year than there was last year, and that's to be welcomed. I think, you know, things are moving in the right direction. What bothers me is what happens next winter, because we never seem to get ahead. But I'm also pleased that there's an acknowledgement in here that demographics is against you, as it will, and you're always going to be looking at increasing demand, and I think that's a sort of something that's I've not seen before, and that's good. Two sort of other point. I mean, I'm a bit stunned that only 6% of the time in a third of the year you thought you were business as usual. That scares me, because if it was any other business, I'd be terrified. But that's just me. Just wanted to check those figures you just quoted about ambulance response times, which are an improvement, which is good. Are they county only or city and county? Because traditionally there's been a separation between the two. And I'll let you answer in a second. The final thing is, there's lots of stuff in here in the slide pack about media and posters and this, but it's all posters in doctors and pharmacies. A lot of people, me one of them, I never go in a doctor's. I've been in a doctor's surgery since my husband was alive, 3 years, thick end of. You know, and you go in the pharmacy every couple of months to pick up some drugs. I don't see it. I don't buy a newspaper, and one press release doesn't do the message. And I know you use Twitter, because I'm a Twitter follower, and I know you use Facebook, but do you actually use those promoted? Because you can, certainly with Facebook, you can have tremendous degree of targeted advertising. And I just wonder whether the communication side could be sort of, I'd say to say brought up to date a bit, but you know, that's what I'm trying to say. So yeah, that's what I was thinking, Chair. Thank you.
So I'll pick up first in terms of, and it's quite a simple answer. Those figures there across the whole of Leicestershire. So that is city and county figures brought together. We're seeing improvements across response rate across all of the areas, but obviously, you know, what we are trying to work through is that county rural response again, how we can improve that, because that is where we see a lot of the outliers. So we are constantly reviewing where standby points are and what crews we've got out there. So, yeah.
I think just the point on the communications, I think the really succinct answer is yes, I think we can and we will, you know, enhance our communication style, approach, targets, etc. We do have to maintain, you know, a balance around catering for folks who either don't have a mobile phone, don't have the modern technology. And to be honest with you, sometimes even when I'm driving down the road, I'm surprised, you know, the radio cuts out occasionally. In 21st century, it's surprising, but it could just be my car. So take the point, we are in that sort of learning focus, and probably what I wanted to get in today was that sort of mentality of continuous improvement. We're not just done, we're continuing to build this throughout in every facet. Okay.
That's very helpful. Unlike Sarah, I do go to my GP practice far too often. And my comment actually is, and I have mentioned it to them at the reception, is they actually have too many things on the notice board. And if I'm sitting there for 5-10 minutes, which I often am, and I start looking, I realise a lot of them have been there for years. And it's very difficult to pick out the latest ones, and certainly it's very difficult to pick out those that really people need to take more care of. And I have mentioned to them, why don't you have a single board that's sort of like the latest news type thing, and it's just where it fits and it's their priority and so on. It obviously is low down, but they just obviously get a whole batch of posters and they stick them on the wall, and if they overlap the previous ones, that's the way it goes. And I think there's a bit of, I suppose, communication, but also perhaps just updating their own way they've always worked, you know. So it isn't just, but I mean, as Sarah says, I know you do put out a lot of tweets and such like, because I get them as well, so it's just a matter of at the moment moving through and making sure there's much as widespread communication as you can within what resources you've got. But yeah, thank you. Okay, thank you very much then. No one else, no. So yes, thanks very much, and we will move on then to our next item, item 11, which relates to the non-emergency transport contract held by Thames Ambulance Service Limited, and obviously based on the fact they've had a recent CQC report, although not on any of the offices in Leicestershire, I understand. So I think you're staying, aren't you, Mike?
I am. You got me for one more item.
Yeah, no, fine.
Thank you very much. We wanted to ensure that we were proactive in coming to members of the committee today, specifically around Thames Ambulance Services Limited, in light of a CQC inspection report, specifically because we wanted to ensure and assure that we're on it and making sure that we're doing what we can to support our valued system partner. Tassel, actually, back for a second, with me today is Derek Laird, the Chief Executive of Tassel, Hayden Newton, who's the Director of Quality and Governance, and Kate Jerram, who's Operational Manager as well. So wanted to ensure we had folks here to answer any questions that may occur. Tassel's now in its second year of operation of a 5-year contract, and we, as I've said, the CCGs and overall in the system have worked quite diligently to build up the service continuity for patients, both upon discharge but also for outpatients related services, including renal dialysis type patients. They are a non-emergency patient transport service, so they are not EMAS. They aren't the clinically qualified transporting medically very poorly patients, but they do obviously maintain particular qualifications. The service includes sort of more low-risk type patient transport, and we do have quite a strict, having reviewed it and updated, I think it was last summer, and we're reviewing it again, an eligibility criteria. So you can't technically get Tassel services and transport unless you're referred by a clinical professional for a clinical need, really. So it's not a taxi service, as it were. There's two main points in the gist of the paper, specifically around performance and quality. From a performance standpoint, performance has been iffy and developmental since taking up the contract and mobilization October 2017. So I think we're in about month 15, 16. There's been steady, slow improvement over that time period through stabilization of the company and services, but also just noteworthy that the Tassel's own performance, specifically on hospital discharge, is often codependent upon how effective hospital processes and discharge might be, but also making sure the logistics are well planned accordingly. So we've worked quite considerably with Tassel to build up the capacity to better meet demand. I think we're getting there overall, and things have improved over the course of winter for the most part. We've been keeping a close eye on. With regards to quality, as I said, we're here in particular around the CQC inspection report for assurance purposes. It's worth noting that I think it's fair to say that Tassel have challenged the report in a number of areas. to clarify particular matters, but also to challenge, I think, some findings. That's correct. And Hayden's going to give us a heads up on where we are with that in particular. But also, as Mr. Chairman, you highlighted, there are certain themes from the CQ inspection report that we automatically jumped onto and went out to the 2 sites across Leicestershire. And whilst there were some areas for improvement identified, they were not similar or the same to what was found elsewhere. It's not to say they don't exist, to be honest, but you know, they only inspected sites across Lincolnshire. Yet, because TASL is a single organisation with contracts across many, from Hull and now I think it's down Mid-Essex way, all TASL contracted parties such as LLR are drawn into the situation, to say the least. So I won't go into all the details and steal people's thunder, but Hayden, if you'd like to give us a heads up on CQC findings.
Yeah, thank you, Mike. Mr. Chairman, the Care Quality Commission review was carried out in October of last year. We were one of the first ambulance services, first of 3, ambulance services to be rated under the new rating regime for the independent ambulance sector. And all 3 have scored at the same level in terms of the review after the review has been carried out by the CQC. Can I firstly say we welcome independent review and scrutiny of the service we provide. We find it useful, mainly find it constructive, and act on the actions and the recommendations that have been brought forward. As well as visits from the CQC, we also enjoy visits from our partners in clinical commissioning groups who will come in, announced and unannounced, to carry out quality reviews at locations within their own locality which meet part of the contract. And again, we work very hard with colleagues in the CCG quality team. We meet every month. We provide a very detailed analysis against some set and agreed parameters in terms of quality, clinical compliance, and also patient outcomes. On top of that, we have feedback from our staff, we have feedback from patients on friends and families, and we triangulate all this information together. I think in terms of the CQC inspection last year, what was unfortunate that we've had a new executive team, a new quality team. I joined and was working from Thames from the end of April. Many of the initiatives described in my paper and the next page of my paper haven't really weren't embedded at that particular time with staff. And the quality team really came into its main at the end of April, and of course the CQC came in October. And I'm not making excuses, because clearly there's some areas here which we need to address, and we will address those. But from the paper submitted by Mike, I'm sure you can see a number of the improvements we've put in place already. And I have a very, very close watch on a day-to-day basis of incidents. So how do we know, is the service safe? Well, daily we get incident reports coming in which are appraised by my quality team, and we action within 24 hours. We've even had the CQC phone and compliment us for work we've done around a very, very, what I would call a discrete safeguarding case, identified by staff and managed also by the quality team. But really here to try to give you some assurance, and systems and processes we have in place. We have submitted a very, very detailed recovery action plan to NHS England and also to our CCG partners as well, which is reviewed by the Executive Board, chaired by Derek Laird, every week for update and actions before it's resubmitted into NHS England. And we have frequent meetings with NHS England to discuss our compliance against the recommendations of the CQC. There's 13 summary of recommendations, which I've summarised in part of this paper, and our recovery action plan includes a total of 28 different actions for various members of TASL to undertake against a timeline which, as I say, has been agreed with NHS England and our commissioning CCGs. The inspection lasted for a day. It visited 4 locations out of the 16 with Thames. I saw a handful of our staff and a few of our vehicles. We have asked them to come back to do a re-inspection, because some of the information that we submitted, and we submitted a provider information request, Chairman, if I can tell you, the attachments to that equaled 70 attachments to a range of different compliance requirements, and a huge amount of work to make sure the CQC prior to the inspection were provided with the information needed to understand where we were with many of the initiatives we'd put in place. So the action plan is reviewed, the RAP is reviewed by NHS England, as I say, on a weekly basis, and the Executive Board have distinct oversight of the actions associated with that. We also have established a CQC action group, and we deliver the requirements of the action plan and identify any other non-compliance issues which we believe that need to be addressed. So very much for me, disappointed by, and the team, disappointed by the rating. For us, it's work in progress, and as I say, welcoming the CQC to come back to do another visit to reappraise our situation with the initiatives that have gone in place. Thank you, Chairman.
Yeah, thank you. Yes, I recall now, I think, when the Health Service Journal published the initial report, and there was, in a way, a criticism of CQC, actually, not
Yes.
just TASL, but the fact that they had just zeroed in on a few places in Lincolnshire, and they hadn't looked at the whole organisation.
Yes.
But I mean, clearly, they've got their own capacity problems. But
Yes, they have.
Thank you, Chair. I'm kind of very aware of the kind of patient transport issue that actually predates TASL, to be honest with you, and the kind of the issues and concerns that's been highlighted. So I think there's potentially kind of legacy issues at play, and certainly from speaking to EMAS, they've always said it's a bit of a poison chalice, to be honest, but that's another issue. What I'm curious and interested in is how you're monitoring and measuring patient experience. The kind of at Health Watch, kind of over the kind of the time you've been embedding, we've certainly not kind of had the volume that we've had historically, but we've certainly had some issues and concerns around kind of eligibility and some kind of disparity around that. So yeah, just really curious and interested to find out what you're doing around that.
Very happy to answer that. As part of the changes we introduced from April last year, we recruited a head of patient experience team. We established a dedicated patient experience and polls team to deal with concerns which were raised by patients, and these are reported on a monthly basis, the formal complaints, into our clinical commissioning group colleagues. And we also feed back to our staff the issues associated with patient complaints, and regular reports go to the Executive Board regarding the number of complaints received on a monthly basis and the impact. And the number of complaints have reduced. The number of issues associated with eligibility criteria continue to be a challenge, where we've implemented an eligibility criteria which probably wasn't the same as what was in place by the previous provider, and people who had transport then may find it's more difficult to get transport here. We have agreed a review and appeal process which involves our PET team. Once a patient has been, if a patient has been refused transport by the control, it's referred to the PET team. If we can't resolve the issue, then it then goes on for a discussion with the clinical commissioning group. But you're absolutely right. Eligibility is the thing which is coming in, as opposed more to formal complaints, concerns around eligibility and transport issues changing. Thank you.
Okay, thank you very much. David.
Sorry, can I just add? Sorry, can I just add? Just in my previous role working for the CCG down in Sussex, we got highly involved with Health Watch. We did a lot of work for us, and I'd just like to invite you, if there's something you'd be interested in working with us to get what the patient experience is, we'd be more than welcome to do that.
Sorry. Very much. David?
Thank you, Chairman. I'm trying just to grasp the content of this report. I appreciate that pages 75, 76 and 77 relate to Lincolnshire, Grimsby, Spalding and Lincoln, but that's not a million miles. Those places are not a million miles from here, and then on page 78 we have a summary of performance, which also contains some disturbing statements. Do the statements on page 78 and indeed 79 apply to the whole of the area covered by TASL, or is that simply in response to the report responding to the Lincolnshire problems?
Just to clarify, the pages relating to the CQC inspection report reflect the overarching actual CQC inspection report, and the item 17, I've got a different page set here, around performance relates specifically to LLR orientated performance of TASL. Apologies, I didn't clarify that within the paper.
Cameron, there are still some disturbing references on page 76 then, so that does in fact cover the Leicestershire area. I take it from what you were saying that you are accepting that these are outstanding matters which are now being addressed. Could we actually have an update, a fairly early update on how these issues are being addressed, Chairman? Because they are serious. The issues in Lincolnshire are very serious indeed, but the issues in Leicestershire should be of concern to ourselves to ensure that the problems identified are now being addressed.
I think that's quite sensible. We obviously need an update, don't we? Imagine you're happy to provide that, as obviously you need a bit more time, but as you said, you put a big report in back to and hopefully the CQC will come back. So
the overarching CQC inspection report reflects the entirety of TASL, which is what the page 75 through to roughly 77, 78. And that there is an overarching action plan associated with that from TASL, agreed with CCGs and NHS England regarding response to that to ensure those things don't happen again. You want to add?
That's the action plan, Chairman, I was referring to, which is updated by the Executive Board every week and then goes to NHS England weekly and CCGs.
Yeah, sorry, I'm still confused. 75, 76, 75 certainly it relates to Lincolnshire, but 76, yeah, but the top of the page it talks about Leicestershire. And this is still referring to Lincolnshire, is it?
Yeah. So everything. I understand.
25 points from the CQC report.
Well,
lettered
sorry.
A to Y.
Sorry, where are the 25? On
So pages 75 to 77, they're all lettered A to Y, little a, little y.
Just as a point of clarification for drafting it, it was literally a copy and a paste from the actual CQC inspection report, which identified the issues.
Yes, Mr. Chairman, it was Lincolnshire bases only.
I know it's me, but and I do recognise the places in Lincolnshire which are a concern. But do I take it then that there's a list here somewhere which just relates to Leicestershire, because that's what I'm trying to focus in on? What part of this report refers to Leicestershire and to the people we represent, as opposed to presumably an area in Lincoln, the area of Lincolnshire, which is being covered by a separate committee. What is it? Page 78. It starts.
Yes, yes, sir. The performance section focuses solely on LLR, but because the CQC inspection report is across all of TASL, irrespective of sites, even though the inspection was specifically at Lincolnshire sites, it's relevant to LLR to ensure that we are consistent and our provider is consistent in terms of how they respond, because the concern largely regarding the inadequate rating was that it elicited themes, and part of the challenge back to the CQC has been about, well, it's difficult to make those assumptions about themes across, say, Lincolnshire, Northamptonshire, Leicestershire or wherever else without having actually visited those sites. So apologies for confusing that within the paper, sir.
Could I make the point, Mr. Chairman, please, that all of the actions we're putting in place apply to every location, irrespective of where they are? Thank you.
But as you say, because we're Leicestershire and we look after Leicestershire, that's why.
And we will actually have an update to show people that things.
Yeah, I mean, there obviously will be ongoing work, and I think we'll be monitoring to see how they're getting on with officers, and they'll be talking to Mike and seeing how the commissioning is going, because effectively that's what we're yeah. Got a bunch of speakers. Questions? Ted.
Laird would like to speak.
Sorry. I just want to reassure the committee. We've last week we were updated from the CQC that they will be. We've asked for a revisit. I don't know if that was a good idea at the time, but we've invited them back, and it's not normal practice, but we have some issues regarding the report as identified, and we have to get all the information to them by the end of, it's 28th of this month, and they've said they'll come and revisit us within 3 months of providing that information. And we do expect that they will revisit other areas within our organisation. So I'd be surprised, considering that Leicestershire is our largest contract. I was surprised before they didn't, because they went to Spalding, which is very small in comparison to Loughborough and Leicester. We do anticipate they will be visiting probably Loughborough, and we'll clearly let you know how it went.
Okay, Ted.
I've got professional experience of working in a transport depot in the private sector. So my questions have focused around more the fleet and the operation, if that's all right. And what I've done, I've gone through the report and I've looked at various points on different pages, but they all interlink. So, for example, on page 76, point R, it says staff morale was low. And then on page 77, point S, you've appointed a fleet manager and there was an improvement in fleet. But, I mean, for example, what was the reason that a depot was hired in Lincolnshire that didn't even have running water? So that would be the first question. And then we can go to page 76Q. It says workloads was so great that drivers were not getting breaks. So what has happened with the fleet now in terms of maintenance, cleanliness, staff rotas, so that the staff are getting... You can see why the vans are dirty, the ambulances are dirty, vans, because certainly in Spalding, this one in Lincolnshire, there's no running water, but if you're too busy and you're already late, you're certainly not going to have time. But I suspect this staff morale issue would lead to the fact that the motivation to clean them is incredibly low, presumably because you want to finish your shift because you've been working so hard. And the last question is that in terms of managing your fleet, do you have trackers on all the vehicles, and are you able to monitor the driving performance in terms of the how well they're actually being driven?
Thank you, Ted.
Can I answer the issue at Spalding first? We do have running water at Spalding. What it is, the water is not in the air, the running water is not in the right area to do the vehicle cleaning on a day-to-day basis. That situation has now been resolved, and the landlord was prevent us installing the water system we needed.
I understand that. I probably would have thought that searching out for a depot that had all of that in place before taking the tenancy.
Yeah, people are commenting about the fact that ambulance staff can't wash themselves. How can they keep patients clean?
So if we can move on to the in terms of fleet management, in terms of the first point was in terms of staff rotas so that what are their workloads like? Are they able to are there sufficient staff and vans to get to the calls on time, to get to hospital on time, leave hospital on time, and do they have sufficient time in their shift to look after the vans? And then the last question was in terms of actually managing. Has the fleet manager instigated a system of checking the safe driving of these vehicles and almost a GIS system of tracking where they are through installed trackers on the vans?
Okay, if I can try and pick up those, please let me know if I haven't picked up one of them. So we go from back to forward, because I remember your last one easier. We're just about introducing a company called Masternaut. I don't know if you've come across those. It's certainly something I've used in previous services I've worked for at West Midlands Ambulance, etc. And that will do exactly what you've just said. It will check all the speed that the vehicle's going. It'll check the driving capability, in other words, if it's rocking or if it's speeding, accelerating too fast. It'll check all the brakes. So it's a comprehensive package that we've just agreed at the board 4 weeks ago, which is now being introduced. Please, Kate, if I'm saying anything incorrect on the rosters, I think we've revised the rosters to reflect much closer. Certainly, I've been with the organisation 11 months now, so we've now done that. That more closely reflects the work that we do. We do, however, as I'm sure you're aware, with the hospitals, get a lot of daily challenges, because you would anticipate, and certainly when I joined the service many years ago, most of the work was pre-planned 40 hours before. Nowadays, 20% of our activity is on the day, and it's generally towards the end of the day. And trying to balance providing a safe service for patients, working with the hospitals around capacity issues on discharges, and allowing our staff to have breaks is sometimes a bit of a challenge. We do what we can, but clearly from time to time, staff won't get the meal break within the time that we'd rather have that. But we do allocate meal breaks within the daily plan. But the daily plan sometimes changes depending on capacity of the hospitals. Running water, I think we've got running water in all the stations. I think the issue was around the station at Spalding, where we got particular issues where the landlord would not allow us to have water where we needed to wash the vehicles, and that's now been resolved.
So the last question then, Chair, would be how long does each driver have at the end of shift to clean the van before they're finished for the day?
Okay.
Yes, there's two aspects of vehicle cleaning we have. We have a dedicated, what we call deep cleaning team in place across the whole of the group, which is 7 people with their own equipment, own vehicles, will go around and do the vehicle deep cleaning within contract terms, which is once every 12 weeks. That's a real deep clean. At the end of each shift, staff have up to 20 minutes to do just a wash down of the vehicle inside. The wiping down of the vehicle from any dust or spillage during the day is done during the day. They carry equipment on the vehicle for a quick wipe, which is a clinical wipe, where we can wipe the work areas down. It's purely a wash down to get the road grime off the vehicle and mop out at the back, then the vehicle's left. I would imagine no different than any other ambulance provider. So it's a provision for staff to do that. And some occasions, if staff finish really late, they'll leave the vehicle, they will notify their station manager that the vehicle's not been washed, and the vehicle will be washed in the morning before it goes out.
It was very ironic, Chair, because it's a small world, because the previous provider, their Loughborough depot, was opposite where I worked part-time, and I used to observe, and it was a very haphazard way of washing their vans. Previous provider, I know.
Bit more extra information, very good. Sarah.
Thank you. I'm a bit amazed you're only fitting trackers now. They didn't think to do it at the beginning, so you knew where your fleet was and utilisation and who was travelling where, and I'm surprised it wasn't actually in the contract in the first place, so that's just an aside. I do note in paragraph 10 that even Leicestershire, not everybody had done the mandatory training. And it does bother me in the Lincolnshire bit that staff are saying they don't know who you guys are. They don't meet you, they have no idea who the senior management is, and I guess they feel a bit directionless as a result of that. And I think it's something you need to get a grip of, and going out and showing your faces and knowing them. Another thing, my minor moan is it talks about the KPIs, which admittedly are improving, because let's be quite frank, it was a shambles at the beginning, as we will remember, because it's been here at least twice before. And I would have liked numbers for the KPIs, because I'm a bit of a sad git like that. Thank you, Chair.
I don't think you're a sad so. I'll make sure that we bring something back in future.
And Amanda.
So, sorry, can I just cover, just to reassure you that we do have trackers now. We have trackers on all the mobiles, so we know where all the vehicles are, but they don't offer the sort of availability such as driver skills and other issues, which is why we've introduced Masternaut.
Can I also assure you, Chairman, regarding Staton mandatory training for Leicestershire? It's now well underway. It started at the beginning of February, and it'll be completed by the middle towards the end of March. It's being done locally by the work-based trainer and team leader at Loughborough Base. Yeah, so that'll be complete by the end of March. And the compliance rate, by the way, for the CQC on Staton mandatory training is 76%.
Thanks for the honesty.
Okay, so I think I'm probably a bit of another sad git. Obviously, TASL has actually come to health scrutiny a couple of times, and Sarah and I have been on the committee over 2 years, but we've also part of the Joint Health Scrutiny Committee, and the TASL has also come to that committee. So this is the 4th time we've seen a report. First time we've seen you, so welcome, but not necessarily a positive thing. I think the thing that I would say is that Grimsby isn't far away, it's my hometown, so I know it really well, which is why I remember the reference in a previous report, and I just had a look at it. You talked in a previous report about the training being done in Grimsby, and it was done at Grimsby College. It worries me that actually we have a situation where the CQC report has focused on Lincolnshire, yet the organisation had designed its service to do the bulk of its training and its actual management out of Lincolnshire. Now, my recollection is you were due to come last February, but you were snowed in Lincolnshire. So clearly Lincolnshire is a really important part of your delivery, particularly for the 3 new services that were implemented at the same time. It doesn't really give me much assurance, actually, that the CQC report has gone in from Lincolnshire, but everything's fine in Leicestershire. Actually, for me, the way that I've seen the organisation develop since the 15, 16 months that I've been looking at this, is Lincolnshire is probably pretty key to your organisation, and I really don't at the moment have the assurance that I think we need, that the Leicestershire service isn't having the same issues.
Thank you for that. We do operate our quality teams to undertake regular visits. We do have our schedules in. The point taken in terms of location of HQ and the impact that CQC has just found. Whilst there are significant areas for improvement, we have not identified through our existing monitoring and quite robust, I used the term earlier, but almost borderline harassing, I would say, folks and systems to liaise with our 2 Leicestershire-based sites. I think one's in Loughborough and one is, remind me where the other one is?
LE4 area.
Right, okay, LE4, which specifically focuses on the continuity and consistency. So the things that were largely found within the CQC, we haven't, our monitoring teams have not picked that up so far. There are subsequent themes though, because you can't be all places at all times. I specifically, my immediate response to this thought, well actually, we would like to have more inspections to make sure that we understand the continuity. Services are provided by TASL elsewhere outside of our immediate region, indeed. And there's a responsibility for TASL to be consistent across the piece. So the inconsistency is really what bothers me to a degree, hence us being proactive here today, and I appreciate your question. For me, I can provide assurance that we are doing what we need to do to take the correct actions to surface any existing issues. Performance, as we know, has not been where we want it to be and where patients deserve and expect, but we are continuing to work with our system partner to get that where it needs to be.
Maggie.
Thank you. Unlike Amanda and Sarah, I'm relatively new to the committee, so I can't go back. But I am disappointed that since the last time you came and you presented to us, that it's only been a marginal improvement. But I'm pleased to hear that you welcome scrutiny, and I suppose the proof will be next time you come to present to us, seeing that the improvements have been made. I mean, the point I'd like to make is that we are dealing with some of our most vulnerable patients and residents within Leicestershire. They're already anxious about having to go to hospital appointments and come back, and it's being compounded by the fact that they're having to wait, or they're worried that they're not going to get there on time. And I think picking up on a point that what Health Watch said, rather than the KPIs, I'd be interested to see more customer feedback and some actual case studies and hear what's actually happening to people and where things are working well and where they're not. So I'd like to hear it from the horse's mouth, please. Thank you.
Could I respond, please, Chairman? We've just completed a friends and family test in terms of feedback from patients, relatives and carers. I'm happy to share that. All the themes and trends from what we call the rapid review panel, which comes out of patient incidents, which are what I was referring to. I looked at a review by my team on a daily basis and overseen by me. We have a themes and trends analysis carried out showing patterns in various CCG areas of patient concerns, issues involving patients. So again, if we can provide that if required.
That would be really useful, and I think it would give us the overall picture rather than looking at stats and things like that all the time.
And I think, if I may, just to add to that, monitoring what's going on is one thing, but doing something about it and picking things up continuously and improving is where our focus is largely going to be. So we'll come back and make sure we share that.
Could I just add, please, Chairman, that on an incident being reported, the rapid review panel will be convened within 24 hours to come up with a number of key actions, and all of those actions will be completed instantly. That will be notification to the CCG, notification to the CQC if required, feedback to the manager, feedback to the crews, and any residual other actions we need to take in terms of the consequence of what's been identified.
Right, well, thank you very much. I think no one else has got any comments. As people have said, it's obviously an ongoing process, and we're very pleased that TASL have got 3 members here. That's very good of you. Thank you very much for coming. And obviously it's an ongoing process, and we hope things will improve as it appears they are doing. So, and obviously locally the CCG, you're managing the contract, so let's see how it goes for the next report. Thanks very much. And so we move on to item 12 on our agenda today. And this is, we're really excited about, it's the NHS long-term plan. You've come. Well, thank you. Well, obviously, we've had Paul here before this afternoon, but I see Kat, you're now. Are you going to lead on this then?
Yes, good afternoon. Thank you, Chair. My name's Ket Chudasama. I'm the Director of Performance and Corporate Affairs at West Leicestershire CCG. You've already met Paul, and also introduced colleague Simon Pizzi from East Leicestershire and Rutland as well, who's been working on the preparation of the long-term plan with colleagues across the system. I'll take the paper as read. However, I may just want to highlight a few salient points, if I may. You'll notice that the long-term plan was published back in January earlier this year, so it's relatively new. But what you can see in front of you in terms of the paper that's been submitted is essentially that this is really a starter, and it's the start of the journey to consider really what the long-term plan means for CCGs and also across the wider system. You'll see within the detail of the plan there are a lot of areas that require covering. And as this is a developing and iterative process in the development of this plan, and bearing in mind it's for the next 5 years, I'm sure that as that detail progresses, there'll be more information and more plans brought back to this particular committee with the relevant officers. So I think it's important to set that at the start. Having said that, a lot of the things contained within the long-term plan are not necessarily new. They were identified principally as priorities as part of our Better Care Together programme that's been running for a number of years, and a number of partners across LLR have been working collectively on for some time. So I think that from an assurance perspective, I think that's good. What people will recognise through the reading of the plan and also within the paper. So firstly, I would suggest that importantly, the plan reinforces the important role of the County Council, particularly in the delivery of the improvements for health and wellbeing outcomes that we need at both the system, a place and a neighbourhood level. And I think that's really important to emphasise that. I think it's also important to state that there are some additional things that have come in, such as there's some lack of clarity around the increasing role of the NHS on both the planning and the commissioning of some of the services which are currently undertaken and commissioned by public health colleagues. I can see Mike kind of nodding his head, and it's one of those areas where I suspect we're still waiting for guidance, and you know, and so I suppose that's probably just a reflection of kind of the state of the plan and how an example of how things kind of can move and shape or maybe take a little bit longer. The long-term plan also doesn't give a firm commitment on the future of specific things such as the Better Care Fund, you know, beyond 1920, and I know that's a bone of contention for a number of people as well, especially so that there's been a number of important projects which have demonstrated some really good impact that I know colleagues around the room have witnessed, whether it's kind of the local area coordinators or Lightbulb or various other things, and maybe kind of running in parallel to this particular process is also the publication of the Green Papers in 2019 around kind of adult social care and prevention. So it's also important how we factor those aspects into the overall production of this plan. You'll see the plan and the paper within your packs refer to the challenges that we have locally and the major challenges around financial balance and the requirement from the plan that needs to be eliminated in terms of deficits by 2023-24. And also the creation of system control totals. So these are some of the things that the plan is actually setting out. It's probably fair to say that as part of this process, we are still working through what's going to happen with the investment, what happens with our finances across the various priorities. So, for instance, how you could realistically achieve all of the ambition that is set out within the plan. I think it's, you know, significantly challenging when you look at whether it's digital, whether it's prevention, whether it's the mental health investment standard. You know, a number of those things are still being worked through to determine, you know, how much each of those areas actually receive in terms of funding and in fact what the funding is actually for as well. So I think it's useful to state that as well. You'll see the long-term plan refers to the development of integrated care systems, and in fact from what that means locally for us is around moving to a shadow form of an ICS by April 2020, so that we're, you know, a year in readiness for the actual requirement by April 21. You'll be aware of the system leadership team, and they have oversight of the delivery of the process and progress to move towards an ICS. Again, I think it's important to say, you know, that's still an iterative process as well, because a lot of work still needs to be done around determining what are the roles and responsibilities at each level, whether it's system, whether it's place, or whether it's neighbourhood. You know, what does the leadership look like across all of those requirements, and also what does the governance look like, and how can the governance enable the delivery and the change to happen. So a lot of work to do on that, but the SLT, as I said, is overseeing that particular process. What I say is particularly helpful locally is that I think we've locally agreed or locally kind of coalesced around what those various levels actually mean. So I think there's from a definitional perspective, system is at an LLR level, place is at an upper tier local authority level, and a neighbourhood level is more at the district or primary care network level. And I think that's been quite positive, and again, it's useful to be able to emphasise that. The plan refers to primary care networks, and again, that's a key building block for the integrated care systems at a neighbourhood level, and across the CCGs, we're working collectively across primary care to help with the development of those PCNs. And at the moment, we're probably looking at around 23 to 26 PCNs across LLR, and they need to be established by the 1st of July 2019. But maybe one of the key points to mention to councillors today is that colleagues in general practice are viewing that as a very positive thing, and it's been well received to date. So that's really good. But essentially, these primary care networks are bringing together groups of practices and other health and social care providers, really working in partnership and continuing the work that we've had to provide sort of personalised care for our patients, and essentially improving the health outcomes for our population. We've got a number of implementer sites that are in place at the moment, and there's one in Hinckley and Bosworth at a neighbourhood level, which is currently in operation, and that includes a GP, a community matron, a social care manager, a couple of local area coordinators, and a patient representative as well. And they've been in pilot phase for a couple of months. And the early feedback from their joint working has been really positive, and it's demonstrating an improved experience for both the patients involved and also for the professionals who are actually involved in those particular neighbourhood teams. So I thought I'd just give that by way of an example of a local feel on the national policy direction. If I may, there's a stakeholder bulletin that's published fairly regularly. Kind of looks like that. That's the February 2019 version. So I don't know whether colleagues around the table have ever had the opportunity to receive and look at that. I can see a couple of nods, so I think that's positive. But the February edition refers to some of the practical improvements that we've had, and maybe if I can just indulge for a moment. There's a lady by the name of Annette Wagg who works for adult social care. When she was describing some of the main benefits, and she was saying that people will be seen earlier before they get into a crisis, identifying preventative measures to be put in place to reduce or delay the need for long-term adult social care services. From a service user's perspective, people have got the opportunity to really just tell the story only once, and then workers can get the right service to the people. So that's been particularly positive. Local care coordinators are feeling very enthused in working in that particular way, especially when they can see patients continuing their recovery at home. One of the patients on that particular group stated that having a patient voice as part of that MDT is really important, especially to ensure that all the ideas are very patient-oriented, and that they've got the opportunity to vet them as real patients, and that's particularly powerful. And also that it provides more confidence that everybody's following the same care plan to aid the patient's recovery. So I just thought for a moment that might just give you a bit of a local take on some of the national policy that's in place. I might just, my final point really is the paper highlights probably some more unanswered questions than it provides answers, and I don't think we're apologetic about that. It's just the state of where it is at this point in time. But I wanted the committee to note that the detail on the development of those plans, is absolutely happening and is part of the continuation of the journey that people have been on for a few years. And that further detail will come back to this committee, no doubt, in the coming months. So I may just pause there. I don't know whether my colleagues want to add any further comments. Otherwise, we'll open up to questions.
Yeah, I'm glad you mentioned the fact that the Leicestershire County Council will be probably, I would say, more involved than the STP. There were some issues about that. And I know she also made the comment, which, I mean, we'll have to see how it goes, but also about the government and the NHS working out just where some of the public health stuff goes. I mean, maybe that's because when they had carried out the consultation, they consulted and various of feedback came from areas where it didn't work. But obviously, Leicestershire, it works very well. And we would like to see that continue. I think it would be rather fair. Anyone? Yeah, Sarah.
Thank you, Chair. I'll echo your comments about public health. I think it would be retrograde if we were to lose it. In fact, I'd like to see more of it grabbed off NHS England. That's another story. It's interesting in paragraph 32 on page 67 that there's a commitment to ensure mental health investment standards are still met. Yep. And I would sincerely hope that money doesn't disappear off into the gloaming and not get spent where it should be, because that's something that's been fought for a long time and very important. And I'm pleased we're getting these primary care networks, and I'm finally pleased they're on a scale that kind of fits with what my brain says seems a good idea. But please don't call them neighbourhoods. 30 to 50,000 people is pretty well all of Harbour District, and there's going to be people in Kevin's division who say, I'm not in a neighbourhood with Market Harbour, and I just call them primary care networks. Get away from this neighbourhood lark, because everybody has a different idea of what that means, and it just, I just think, is unhelpful.
It is mixing it a bit.
Thank you, Chair.
Yeah. PCNs, yeah.
Yeah, I can respond to some of that. So on your first point around mental health investment, absolutely we've been dictated to, you need to meet your mental health investment as part of our overall financial plan, and that's been submitted to NHS England, and they'll scrutinise that and make sure that we adhere to that element of that. So that's there. Absolutely right, our language has changed from neighbourhood and other things to PCN, and we are talking about PCNs. But I think the key point for me is that it does build on a lot of work we've done around locality working. And already starting to work at scale. So although there are some concerns, it has, as Kat said, been welcomed because we've been working towards that. There is some anxieties, what does it look like in the future? We can't quite answer that question. Well, we are working through the mechanics of establishing the PCNs and need to put a proposal by May, I think, ready for implementation in July. So our language has absolutely changed. I think that the test of it will be the transformational element of that moving forward, and the integration element of that, where it will really, really make a difference. I think it is where the test will be.
I mean, I was advised at our pre-briefing meeting not to raise any local issues, but there was a reference there to Hinckley and Bosworth. If I could be, I would like a bit more information about that, if I may, please. You send it to yes. No. I mean, the problem with this committee is that we are all on the same side, aren't we? We all desperately want this to work. We're not, banter apart and all the rest of it. We do desperately want this, all these schemes to work for all our sakes and for all the people, our families, our friends and our loved ones, don't we? And the people we represent. But to what degree is this a set of... I know you're implementing certain aspects of this plan, and that's fine, and we all support them, but to what degree is this a set of proposals which still have to be funded at by NHS England before they can actually be implemented? Is this still basically a set of proposals rather than a plan for implementation at this stage?
So it's the NHS plan has published a set of requirements, and as a result, as commissioners, it's our responsibility to ensure that we plan and commission services to be able to deliver on those requirements. So what you'll see within the back of this particular paper, there's Appendix 1, which has got all of the relevant work streams, and within there is a set of bullets that basically says this is the specific things that we will be doing. You'll notice that the timeframes for delivery of those things will vary. Some will be sooner, some will be the medium term, some will take a little bit longer, some are up to sort of 2028. So those are the requirements set out in the plan that we as commissioners have got a plan to achieve. I think your question around how can these be funded, I think looking at the funding envelope, it will be very difficult to be able to fund all of these things. That's a common narrative that we've had within the NHS and other public sector organisations for decades. The question will come in terms of how we prioritise our investment and our resources to the delivery of these particular requirements.
If I may add just a couple of points on that. From a national point of view, there's a view that there's been a revised allocation of 3.4% above the 2.2% average allocation. So from an NHS point of view, I think there's a revised money into the health economy. I think if you step back, though, and look at the NHS plan, I think at the centre of it is integration. And I think in part it starts to recognise that actually in terms of the workforce, in terms of the money, in terms of the system, in terms of the pathways, we're not going to survive until we start to integrate. And I think part of what it's pushing towards is this vehicle for delivery. So when it talks about PCM, it talks about PCM as a vehicle for delivery for that. It talks about partnership working on an alliance-type basis. It talks about accountable organisations, so into the prime provider type models. And I think there's a reason why this year has sort of been called a holding year, essentially because there's a recognition there's a whole load of work to be done, readiness to start developing and if you want, publishing, I think by September, August this year, in terms of what that plan is going to look like, and that is going to be through a lot of joined up working and everything else. And then the other thing I'd add in terms of the local authority, I think there's only one vehicle delivering on joint commissioning, whether that's called BCF or not. Joint commissioning and pooling resources and that sort of stuff has to happen, otherwise the integration won't happen. So that's very high on our conscience and on our radar.
Thank you, Chair. Just kind of before I go into my question, it's just something I wanted the Commission to be aware of. But every health watch across the country has been commissioned through NHS England to do quite a substantial piece of work around what are patients and public priorities with surrounding the NHS long-term plan. So there will be something that if you don't receive, then please let you know, because I'll give them the details. That's going to be asking for people's what's important to them around their health services and what are their priorities on a number of different things, both in a general sense of the word, but also in the, if you look at the Appendix 1 when it talks about some of the condition specific, because a lot of the work around the NHS long-term plan that is kind of more focused around things like stroke, cancer, learning disabilities and autism. So there's going to be quite a piece of work. So that's Leicester, Leicestershire, Rutland, and also every other health watch in England. So we're kind of picking that up and going to be doing quite a big piece of work.
So when you actually look at the NHS long-term plan in terms of the Health Watch board, and we are going to be expected, I think, to develop a transformational board, a partnership board, and there is a view that there's going to be a far closer partnership between those boards in terms of driving things forward. The only ask I would ask is, if you're doing this piece of work, we probably need to have a discussion to make sure you're part of the work that we are thinking about doing.
We've already been linking into Sue Venables. To be honest with you, it's actually commissioned through Health Watch England by NHS England, so a fundamental part of it has been a discussion with Sue Venables. So actually, yeah, we're already kind of discussing. So okay. Absolutely agree. And I think I just kind of wanted to say, if anyone's had the daunting task of actually reading the NHS long-term plan, it's actually not a bad document considering some of the stuff that comes out of the NHS. And general, it's actually aspirationally, it's an amazing document. I think the point that Paul raised around the workforce, I think that is, yeah, that's the biggest stumbling block. The workforce for what it's needed is a big ask. And I know some of the conversations that we've had, whilst this is all happening, it's the internal communications about making sure that all the different parts of the staffing system know what's going on. So, and not just the ones that are involved in the things that are changing, but other ones that are disconnected, so they're kept up to speed and they see those changes and can be a part of what can be quite a big and substantial change. I think what's also quite interesting is that within the NHS long-term plan, there's a real, towards the end admittedly, but a real focus on patient safety. Actually putting into place specific roles for people that are focused around patient safety, which, given one of the papers at the end of the documents, is actually a really good thing.
Amanda.
It was just a really quick one, really, and it's probably just to follow on from what Michael's saying around staffing. Is obviously the 23 PCNs. Obviously the concern that we would have, my community in Braunston, we've had some real issues with our GP practices over the last sort of couple of years, and one of the things I'm concerned about is actually how creating 23 focused networks will actually make some of the staffing issues feel more acute in some of those areas, particularly where obviously the areas of the city where the GP recruitment is difficult, but also in my area as well, but also the extra staff that will be part of the network. How will we get over that, and what are you planning to support?
I can start to answer that question if Mr. Thing can pick up. I think there's been a number of things to come here previously, so like community service reviews, for example, and one of the focus of that is exactly that. So what does the future look like, and how do we meet that challenge at locality level? So one of the reasons we talked about the pilot earlier on is that it predated almost the publication of the NHS plan. We were already thinking about how do we then develop the integrated workforce. So that discussion is absolutely taking place. Some of our local authority colleagues are doing the same sort of thing around, and albeit the template, the footprint is slightly different, and there needs to be a discussion about how we manage those. So, but there is another element, I think, which is equally as important as the workforce, is actually how do you provide the infrastructure of those PCN to make sure they succeed. And one, as you'll notice within the plan, there is some not more than aspiration, there is a requirement that actually clinical directors per PCN is appointed. I think there's a requirement that certain operational workforce is appointed around those. There is also an ask from CCGs that is reciprocated in kind. In other words, what commissioning infrastructure do we put in place to support at locality level? Now, how is it going to quite work out in some of the other logistics that there is 26, that's something we still need to work through, because you can't have 26 people turning up at various meetings. So we will have to find a way of actually making sure there is a single voice representation or what have you. It may happen through federation, it may happen through other system, but that's the discussion we're having at the moment. But rest assured, we are very much focusing on how do we make those PCN, because they will be a key driver for change and transformation, and we must make sure they succeed.
Good one, thank you, Amanda. I think we're okay. No one else? Yeah, I mean, obviously it's a wait and see, but we're very interested. So, you know, whenever you get something that's worth letting us know about, please do. We obviously we keep up with our aspects anyway, and it's interesting. One of the examples you gave from the thing was actually from Adult Social Care County Council. So yes, okay. Thank you very much, and we'll thank you for all your work. Right, we move on to our final report, which is on the health performance update. And yeah, got one or two people staying on. Some people are gluttons for punishment, aren't they? Yeah, so Andy, are you going to lead on this today?
Yes, I'll kick off, Chair, and then hand over to
Thanks.
colleagues. Yes, the report before you today brings you an update on health performance across the system based on data that was available in February 2019. Aims to provide an overview of the various performance issues which you might wish to ask for further reports or particularly questions around, and informed discussions in health check against future reports coming forward. Kate Allardyce is here, who leads on CCG performance, or pull out some of the issues around that area. And also Natalie Davidson will join us for the public health section at the end, and Natalie leads on public health intelligence. We have added a few extra points to the report this time in response to comments made at the last meeting, particularly around the wider range of cancer metrics and qualitative issues around never events and serious incidents. And also Kate will mention some of the developments that are potentially in hand around NHS mandate and constitution changes moving forwards. So just to pull out one or two areas around the four themes within the document, particularly around the Better Care Fund performance. You'll be aware there's four particular metrics that are the focus of the Better Care Fund performance management framework, with a separate indicator around falls. Metric 1 around permanent admissions for older people aged 65 and over to residential and nursing care homes, where we've got a target of an 890 admissions as a maximum in 2018-19. Looking like the predictions for this year are going to be 32 below that. So whereas the first few months of the year we were over achieving in terms of more admissions than we wanted, that's been brought back in the latter half of the year. So we are predicting that we will come within that target based upon a range of work that's going into care packages and personalised care. And further details are set out in the report on the various admissions. And also in relation to metric 2 on reablement provision, which is a key enabler within the system. We've set a target of 87% for people over 65 who are still at home after going through reablement services, and currently performing at 90.3% for August to October. So again, some good work that's going on around reablement within the system. The target's been achieved in 8 out of the 9 months. Delayed transfers of care, which, as you're aware, has been a very strong focus within the Better Care Fund and within partners. And I'm pleased to be able to report there's been continued good progress in that area. Target's been set for this year in relation to 7.88 days delayed average per 100,000 population, and the system's currently performing at 6.37 delays, which is quite a significant reduction that's been sustained, 32% reduction in total in terms of delayed bed days compared with the same period last year, 12% reduction through UHL, 45% LPT and 28% out of county. So some really good work that's gone on through the Better Care Fund and through partners to sustain that performance. And then finally, the other elements of the measurement system relates to non-elective admissions into hospitals, where there has been some revised targets set for 2018-19. I'm pleased to say that the system is operating within the new planned sort of parameters for elective admissions, which hasn't been the case for the last couple of years. It's not to say that there is a reduction in those pressures, and you've heard about the demand pressures that are in the system, but it is saying that it's within the sort of planned and funded arrangements for non-elective admissions into hospital. And in fact, there looks like there's going to be a slight variance or better performance in terms of elective admissions this year by the end of the year. And also there's a focus on falls through the Better Care Fund programme, and that does seem to be making a positive contribution through a reduced number of injuries going into hospital through falls. So that's a quick snapshot of the Better Care Fund performance. I'll hand over to Kate just to pick up the CCG performance. Thanks.
Thank you. So Appendix 1 and 2 show the improvement and assessment framework that's produced by NHS England, and that was published by them in January. I'll take the report as being read. What we've done is pulled out the key constitutional metrics that are currently not being achieved as part of that assessment framework. So they're the cancer 62-day wait for treatment, A&E target for the 4-hour waits, and the referral to treatment for consultant treatment. So at the moment, those 3 areas are not being met across Leicestershire, and the report does outline some of the key actions that are taking place across our providers to increase and hopefully improve the performance around that. I did also want to just pick up on some areas of improvement as well, because I think it's important to say that it's not all red. So just to highlight some of those. So there have been actually no waiters for over 52 weeks at UHL since June last year. There have been no 12-hour trolley waits since last March at UHL. Andy mentioned earlier about the DTOC levels, and they've been particularly low, and certainly within the tolerance levels for UHL, particularly low levels in November, which is encouraging. Don't talk about this very often, but personal health budgets, the two CCGs were in the highest performing quartile across England for Q2 this financial year. And both East and West are achieving the dementia diagnosis rate, which is at 67%. The report does also include information on cancer metrics, but I understand that's been covered probably in an earlier agenda item by Paul, so I don't propose to go through that. And then the committee also asked for some information on never events and serious incidents. So we've taken some information from UHL. Now, UHL did provide quite a lengthy document for us on this, so I've summarised some of that, so hopefully you'll find that of use. And if you did want any further information... Oh, you've got the documents at the back, okay, so there's a lot of information if you wanted to look at that in more detail. But really, just to outline that certainly on Never Event, UHL are not particularly different to their peers or any local providers either. So, as I say, there's plenty of information within your pack. Just wanted to mention about the current, the 1920 planning round. So we're in the midst of that at the moment. On page 107, I've outlined there the new metrics that we'll be reporting on next year, and there's a real focus there on primary care and mental health, so that's really encouraging. And as and when information comes out on those metrics, they would, I'm sure, be included in reports that come to future HOSC meetings. Also, earlier in the week, you'll have seen some media interest in changes that are being proposed for financial year 2020-21. So there are some significant changes expected, and they could well change the constitution metrics as well. So they're really around access to mental health services, elective, emergency and cancer. So again, as and when we get more information out, they'll come to the committee as well. Okay, so on to the public health outcomes.
Yes, hello. So Appendix 3 sets out the latest public health outcomes performance. So we had an update in February around the national indicators. So just to draw your attention to the breastfeeding data, this is the first time that we've had breastfeeding data published for the last 3 years. And this shows that Leicestershire performs significantly better than the national average, with 45% of our mothers breastfeeding at 6 to 8 weeks, whereas nationally we stand at 42.7%. We've also had some updated data around life expectancy. So this continues to show that Leicestershire performs significantly better for life expectancy and healthy life expectancy for both genders. So compared to the previous year's data, life expectancy has increased by 0.1 years, for males and females, whereas healthy life expectancies remained stable for males, but declined very slightly for females, only by 0.1 years. You'll also see in Appendix 3 that we are still red on a number of indicators. These are just 3 around chlamydia detection rate and also around health checks, which there is no update, so that is something that we have continued to perform significantly worse around this. Just to draw your attention to the NCMP data at 4 to 5 years, so this examines the percentage of children with excess weight as measured in schools. Unfortunately, Leicestershire has now flagged as being significantly worse than the national average for those in 4 to 5 year olds. It's reporting that 24.3% of children in this age group are either overweight or obese. The one thing I really want to draw your attention to is that this is due to a data quality issue. So in Hinckley and Bosworth, unfortunately, there was an issue with the recording of the data for the children in that district, which has caused a big increase in that data. So previously we've always performed significantly better than the national average. This data quality issue with the recording has caused us to perform significantly worse for the first time. When we delve deeper into the data, the Hinckley and Bosworth data on all national reporting has been suppressed due to this issue. However, it has not been suppressed at a Leicestershire level, which is causing that increase. So it's really, really important to remember kind of the local knowledge of what's happening around this indicator. And I was going to stop there.
Thank you very much. Yes, it's just this. It's just these.
No, it's yours.
It's these height measuring machines in Hinckley and Bosworth that clearly they've chopped a couple of inches off the bottom.
No, it was about an inch actually.
Anybody got any comments or questions of this? I mean, yeah. I mean, overall, as you say, it's helpful to have this information as we get it each year, and there are some improvements, which is always good, isn't it? And especially obviously the Better Care Fund stuff. That's great to see. As you said, the details, if I can call it that, on the some of the problems. We did get, as I said, in the end, I think the officers realised that it was perhaps a bit too much to put the whole report in. So we got it as just a read, but yeah, we've taken your comments, and they always are interesting, no matter how many there are, sadly, because by their very nature they are obviously exceptional, and one hopes there aren't many of them, as there aren't this time. Yep, Sarah.
Thank you, Chair. I mean, we've been through a lot of the detail of this before we got to your report, so in a way we've talked ourselves out. One thing I did notice, just to prove I do look at the detail, on Appendix 1 and 2, 122C, 1 year survival from all cancers, target 71.9, actual 73.3, and you've got it as a red. Now, given that's a higher number and you want people to survive, shouldn't that be a green? And they've wrong on both of them. Thank you, Chair.
So this has literally been cut and pasted from an NHS England report. So I suspect the target, is the target the same on both of them? So, yeah, so I suspect that will be a national average. So that's right. So, oh, yeah, you're absolutely right. So it should be. Yeah. I'll feed that back. Thank you for spotting it.
It's just a point of clarification, actually, regarding the delayed transfers and the improvements and everything, and the fact that the housing enablement team will go into the integrated discharge teams. I thought they were already there, but am I reading that wrong?
I think that may be an action that has been implemented before, so this was trying to summarise some of the actions that have either been implemented or underway to support detox, so you are, I'm sure you're right on that.
Looks like you've worn us all out. But no, it's tremendous. I mean, these are the papers that we like to read each year, and it's interesting to see how, obviously, the variations are, but it does look like, on the whole, we're winning slowly. But thanks very much for coming. Thank you. Right, and the final item on the agenda is the date of the next meeting. You'll be glad to know. And that's due to take place probably in the summer. Well, maybe someone will appear by then, on the 5th of June. At 2 o'clock. So thanks for attending. And, gosh, I managed to finish before 1:30.
I didn't mention that my name wasn't on there. Should I mention it?
No, I've told him already.